We're just starting the recording. Welcome everybody to the Maine Rural Healthcare Education Grand Rounds. My name is Dave McClellan. I am the program manager for the Merge Collaborative, which is a co-sponsor of this Grand Rounds with the Building Maine Network. And thank you to our grant of the building from the Department of Health and Human Services from the state of Maine for making this possible. All right, we have some amazing presenters today. It's actually a team, so I'm going to hand it over to Wyatt to introduce the group here. And as a reminder, folks, we'll leave cameras off until the Q&A, and in that Q&A, we'll have a great discussion at the end of this. So Wyatt, why don't you go ahead and introduce what we're going to see today?
Well, thank you very much for introducing. My name is Wyatt. I'm a third-year medical student in the Tufts Main Track program. I'm interested in going to family medicine, and I'm here representing the Tufts Human Rights and Asylum Clinic, which is a student-run organization. It's part of the National Physicians for Human Rights sort of network of student clinics. And I'm here to talk about the way that we provide trainings and mentorship and get student involvement around asylum medicine. I have two very gracious physicians who I convinced into joining me today. The primary presenter who we have advertised on our flyer is Dr. White. She can sort of turn her camera on and wave if she'd like. She was an infectious disease specialist at Memorial Sloan Kettering Cancer Center. She helped establish the Cornell student clinic for asylum medicine, as well as was an evaluator at the Icon Mount Sinai School of Medicine Asylum Clinic, and then most recently helped set up our Tufts student asylum clinic. So she's really an expert. She's run a lot of our trainings, is a avid mentor for our new evaluators, continues to do evaluations for us, and is here today. We're very thankful to have her. We also have Dr. David Moltz, who's joined us. He is representing the mental health and psychiatry side of asylum medicine. He's also going to be talking about how he mentors new evaluators, particularly sort of to bring in the remote aspect of the work that we do. He went to medical school at Buffalo, I believe, SUNY Buffalo, and then worked in New York, did residency at, now I can't remember off the top of my head, but he can chime in and correct me, but did work in both community psychiatry as well as addiction psychiatry, and has been in Maine for a couple of years now. So we're very grateful to have him here as well. I also have one of my co-leaders, Hannah Guto, here, who's going to help answer any questions that I don't know the answer to at the end of the slide. So I'll go ahead and just jump right in. We don't have, thank you to the Maine Medical Center. Thank you to Merge. Thank you so much to allow us to be here. We don't have any conflicts of interest or disclosures. And I'll just go right into the presentation. So we're going to be talking about asylum medicine today. I'm going to, I gave a quick introduction in terms of Dr. White and Dr. Moltz and myself, representing the Tufts Human Rights and Asylum Clinic. We have a little QR code there. We make pretty liberal use of QR codes in this presentation, so feel free to scan. That's just a link to our website, and we'll have some other resources later on. Objectives for today, we're just going to recognize the clinician's role and really talk about what a forensic evaluation and a forensic medical evaluation is for asylum applicants. We're going to talk about techniques in remote mentorship and how to sort of help health professionals utilize skills they already have and apply them into new areas. Then we're going to talk a little bit about trainings. We do in-person trainings. We also offer a remote training program online. We're going to talk a little bit about how we train people to do these evaluations. And then really the secret fourth objective that I'm most excited about is I really would like to convince everybody here today that this is important work and try to get some of you involved in doing forensic evaluations if possible. Just have a quick little agenda here. So I'm going to very briefly talk about what asylum medicine is. I'll then hand it over to Dr. White, who will talk a little bit about how we train people to do these evaluations, give you a little bit of a taste of what a training is like. Hand it over then to Dr. Moltz, who will talk about mentorship for new evaluators. Then I'm going to chime in again briefly, you haven't got rid of me yet, and just really push how you can get involved in this work, and then we'll turn it over to questions and answers at the end. I can't see you all as I'm presenting this, so if anybody has any questions at any time, please just interrupt me and chime in, and I'll stop talking. But just to go right into the body of the presentation here, I want to just lay out a couple definitions, because these are terms that you'll often see sort of used interchangeably, and there is really pretty strict legal definitions in terms of what each of these words mean. So a migrant is anybody who's moved for any reason away from their place of residence. So Dr. Moltzen and Dr. White have both come to Maine from New York. They're migrants. Doesn't matter what the reason was, they've gone from one place to another. So that's a very broad definition. Refugee gets a lot more specific in terms of the law, where it's somebody who has left their country of origin. So they've moved from the country that they're originally from for a specific set of reasons. And that's because of persecution or fear of persecution due to race, religion, nationality, a sort of broad definition of membership in a particular social group, which can apply to a lot of things. In terms of our work, we see a lot of people who maybe their HIV status or their LGBTQ status involves them in a particular social group, and then political opinion. So very, very defined subset of people. And those are people who have left their country or are now in another place. An asylee is somebody who meets that definition of a refugee, but is now present in the United States. So they've left their country and they're now here, and they're essentially applying for a permanent resident status or a green card status. And by the rules of the law, they have to apply for that status within 1 year of becoming an asylee, so somebody who was a refugee who is now in the United States. So just some quick definitions. Really what I want to emphasize about asylum is that it's a discretionary process in which somebody is applying for that status here in the United States and is asking a judge, can I please have a lawful resident status to be here? And it's really just up to the judge to say yes or no. And that's essentially the crux of the law. And it's on the judge to determine whether they believe the person's story is worth granting asylum, whether their experiences are trustworthy and valid, and meet those definitions of what would make somebody a refugee and an asylum applicant here in the US. So because really the determination of whether someone is granted asylum or not is up to the judge, there's a lot of leeway in place for physicians to intervene and really increase the rates at which asylum is granted. And that's by providing forensic medical evaluations, which I'll get into in a second. I just wanted to give a very quick update on the state of sort of affairs nationally and in Maine at the current time. I know there's a lot up in the air around this issue right now. The most recent data in terms of numbers that we have comes from January 2024. There's not a great sort of organized system in which we're keeping track of refugees and migrants and asylum seekers, but just in Maine, there's about 50,000 foreign-born individuals. It's about 1 in 25 Mainers. Around the Portland area is the greatest concentration of people who were born from outside of the United States. So it's actually about 1 in 10 people in the greater Portland area. And this is on the rise. Those numbers were like a 50% increase since 2000. And likely the numbers are higher this year than they were last year. Regarding some more current state of affairs in terms of the administration and changes in laws. So currently, the refugee admissions program has been frozen. So the U.S. is not accepting and redistributing refugees in the way that it has through previous administrations. However, asylum does continue to be granted, and in many courts, the rates have actually gone up in which asylum is being granted. So there is still room for people to make a difference in these asylum applications. I also just wanted to pinpoint a sort of mind-boggling statistic in which there's an estimated 10,000 ongoing asylum cases here in Maine. So that's both people who have just arrived here and are applying for asylum, as well as people who are in various stages of removal proceedings or deportation and are applying for asylum in that way. So 10,000 people, and some of those people, they got here 10 years ago and they're still waiting on their case to be heard. And then we have some people who just got here last month and are already sort of in this process. So just a state of affairs. My last slide before I hand it over to Dr. White here is just to introduce what a forensic medical evaluation actually is. It's really something that any medical professional could do. It's a pretty standard part of your medical practice, just formatted. Instead of seeing a patient for medical treatment, you're seeing an asylum applicant for a legal document, essentially, that you're going to write. So it's to obtain facts pertinent to the asylum seeker's history of whatever persecution they may have experienced that would make them eligible for asylum here. Obtaining facts just like you would in any sort of medical physical exam or evaluation. So that includes, if it's a medical evaluation, a physical exam. Dr. White will talk about documenting evidence of physical trauma, such as scars. If it's a psychological evaluation, like Dr. Maltz will be discussing, really focusing on that history, doing mental status exam, identifying possible psychological sequelae of any trauma that's been experienced. And then really this key important last bullet point is establishing consistency. Like I said, asylum is discretionary. Judges love doctors. You're a medical expert. So if you can provide that expert opinion that the asylum applicant's story is consistent and they have physical or psychological findings that relate to what they've experienced, it hugely increases the rates that asylum is granted. And I'll give a specific number later, but that's just my quick introduction. So I'll hand over the presentation to Dr. White. And whenever you want me to continue slides, I'll continue on.
Thank you very much, Wyatt. And thank you very much for inviting us. It's very exciting to be invited to sessions like this where we can talk about how gratifying this experience is. And we're very, very welcoming of anybody across the state who might be interested in working with us, because it really is one of the most essential items for many of these people's lives. And it's wonderful to be able to make a difference in that way. The main question that you will be approached with in terms of evaluating the asylum seeker is, are there findings which are attributed to the reported events? And if so, as Wyatt mentioned, are the findings consistent with and are they specific for the reported events? Next slide, please. So first of all, during the training sessions, which usually last about 3 or 4 hours, they will be giving you a variety of examples of types of physical torture. For example, I would say that blunt trauma is the most common type of physical torture. Most people have experienced it if they claim physical torture. However, it is also something that doesn't leave a lot of scars unless a person is traumatized repeatedly in certain areas. So there are many, many other types of physical torture which can help the case for the person who is claiming that they have had torture, such as burns, electric shock, and even items such as when you are incarcerated for any reason in a cramped or solitary room, unhygienic conditions. All of these are considered types of physical torture, and these are the types of events that many people who are seeking asylum will report. And we will go into how to identify these particular items, particularly, and also how to ask for them so that you can provide it in an affidavit. Next, please. And then there are types of psychological torture, which will also be discussed. Here it's 80% of cases in which a psychological diagnosis is made. But if you can imagine that you left your home country, family, and every other aspect of your life in fear of dying, then you have been suffering significant psychological trauma. And so I assume that every single person who is seeking asylum has had some sort of psychological impact. And it's important that we identify whatever they are and how we can do something about it. These types of psychological torture are not just the fear of death, but also denial of privacy, again, being forced into some sort of detention, harm to others, harm to oneself, harm to family, betraying others. All of these are considered psychological torture. Next, please. So one of the most important things that we should tell people about who are interested in this work is that the conditions for the encounters can be quite different from your normal, intake, history and physical that you might do for a patient. So first of all, the location can be at an office or clinic. It could be yours or you could be borrowing it. but also it could take place in detention centers. And unfortunately, I've had to do evaluations in lawyers' offices when nothing else could be found. And that is one of the concerns that I've had in terms of visual as well as auditory privacy. But it is considered a safe place, but you have to be aware that there are all sorts of circumstances around these events that are not always ideal for evaluating these clients. What to wear? Don't wear a white coat. Most people have either been tortured by people who are claiming to be state actors, such as police or military, or else they have appealed to the police who wear uniforms and who do not help them. So a uniform can really stifle the whole conversation up front. So we generally do not recommend people wear white coats. But we also say, if you are going to be in a different place, certainly not your office or the lawyer's office, you will want to bring several things that you can use to evaluate the client. You will be bringing your own stethoscope, measuring tape, lights, gloves, pen lights, Snellen chart, whatever you read in the affidavit might be necessary to document in the evaluation. You also will you can either have a handheld camera or use your phone to document any injuries or positions that the client may have taken when they were being tortured. Many of these cases also involve an interpreter, and that is another very important thing, that establishing a relationship with the interpreter in advance of the evaluation and also making sure that the client feels comfortable with the interpreter. The most important thing is time. I usually measure out 2 or 3 hours so that I have plenty of time to elicit the information. The client has time to actually recover from reporting once again the events of their torture. They often need to take breaks, go to the bathroom, have a drink of water. And it's important that you are as relaxed as possible when you are doing these evaluations so that they can be relaxed and you should feel like you have all the time in the world for this so that they can reveal what needs to be revealed. Next, please. So it's a focused medical history. For instance, you won't ask about every case of malaria that the person ever had. You will be focused on the events and the sequelae of the torture. So in addition to obtaining past medical history, their medications or allergies, you will be wanting to know, where did the event happen? Who else was there? How many people were there? Were they wearing uniforms? What language were they speaking? Body positions, the client's own body positions during the event or the actual torture can be very important, and I'll go into that in a little bit. And I photograph those if they're relevant. You will ask, well, what were you tied up with? What were you stabbed with? What did it look like? How long was it? So that you can get a clearer picture of what exactly was going on at the time of the torture. And then the most important part is the descriptions of the acute and chronic wounds. So you will say, well, when they cut you, was there a lot of bleeding? What happened then? Did you go to a hospital? Did you go to a clinic? Did you take care of it yourself? Did you get local treatments from a community person? And then you would say, well, how long did it last? Did it get infected? All of these will help you when you are describing the actual findings at the examination to explain why they look the way they do. So next slide, please. So scars are the most common of physical finding after trauma, except for, as I said, no findings, such as after blunt trauma. And so evaluating the scars will be very important. It's one of the things that we spend the most time during the training session on. And so you will know that since there are so many ways that a single piece of injury can heal and be impaired by so many other things that might be influential in the particular case, you will want to know, again, what type of trauma, whether they got medical treatment, if there were infections, local remedies, repeated trauma, et cetera, et cetera. All of these will help you, again, in explaining the abnormality in the scar. So the next slide, please. Again, we are asked to find what are the events, what are the findings attributed to the reported events. So I've covered that. But then the real question is, are the findings consistent with, and are they specific for the reported events? And this goes back again to what Wyatt was talking about, a way to convince the judge that this very likely, what the asylum seeker is reporting very likely occurred. Next slide, please. So in this case, we'll be discussing the application of the Istanbul Protocol. This Istanbul Protocol has been around since approved by the United Nations since 1999 and then updated in 2022. And these are the standards for evaluating the sequelae of physical trauma. And this is the tool that you will learn to use in terms of describing the findings that you have on it in evaluation. The first one is not consistent, could not have been caused by the trauma described. I've seen that very rarely. It's not typical. Usually you wouldn't get a case that claimed that there was an injury if it were not likely in some way to have occurred. Consistent, that is the most common that I have seen 90% of the time. And in that case, it could have been caused by the trauma described, but it is not specific for the event. So if, it could have been caused by that knife, but it could have been a kitchen injury that caused by a knife. So that is, but that is a consistency, and it's still a very useful tool. Highly consistent, there are a few other explanations for the findings. Typical, usually found with this type of trauma, but there could be other causes. Diagnostic is extremely rare. Unfortunately, I've only seen it once, and in that case, it was a tattoo over a client's genitals, and that was diagnostic. But most of them, as I say, are consistent, which is still a valid recommendation or conclusion from the evaluation. So next slide, please. So I want to give you an example of how you can evaluate clients. So this woman was trying to prevent some abductors from abducting her sister for sex trafficking. And while she was trying to protect her sister, one of the perpetrators wielded a knife and cut her up. And so she says that this is the knife wound. You can tell that it is something that could have happened with any kind of injury. She could have scraped on something. She could have been hit could be a kitchen injury. It's non-specific. And I think I would just say it's consistent with, but not specific for. And next slide. But then I asked her, how were your arms when you were being attacked? And you can see here, she then put herself in a defensive position. And you can see that the left arm injury is very clearly right in front of her and would have been accessible to the perpetrator. But also on the right arm, you see now midway down the arm that there is another scar. And she said that also came from the attack. In this case, I said that this is highly consistent because the fact that she was in the position from basically a knife wielding attacker and has this kind of scarring, that it is very likely that that is what happened. So this is the kind of thing that you will learn to demonstrate for the judge, so that when you do believe that the asylum application is valid, that you will do things like this to show that from a medical point of view, this is very likely to have been the outcome. So last slide, I think. So when you conclude the evaluation, you always thank the client and the interpreter, but you should take a couple of days away from the case It's an emotional experience for you and for the client. And you have to write an affidavit, which is objective and non-emotional and very clinical and factual. So it is not a good time to start writing your affidavit. So I usually take take those days away, and I will have been writing notes all along, so it's not a concern about remembering anything. And then I will write a draft affidavit. During the training, you will learn how to write an affidavit, um, at, and you will also be mentored on how to write the affidavit. Then you will discuss the affidavit and finalize it with the attorney. And then very rarely, that's usually the outcome. That's all the work that you have to do and just await the outcome of the judge's opinion. Oral testimony is very rarely requested. But I do want to just end with one particular thing that it is one of the most rewarding things to have basically helped get asylum for this client. This person would otherwise have to go back to their home country, usually involving their death. And so you have saved a life by spending a few hours on this process. And I can't recommend it highly enough as one of the most rewarding things that you can do. So with that, I'd love to pass it on to Dr. Maltz.
Okay, thank you. I would agree with that last statement. People worry about secondary trauma from working with people who've been traumatized. My experience is that when you can be helpful to them and really make a difference in their life, it is extremely rewarding and a very, very good thing to do. We're close to the question time, so I'm going to go rather quickly, I'm afraid. I do have to say that I've been here 35 years, not a couple of years. And all the work that I've done around this area has been done in Maine. Before the first slide, when I started my first evaluation, I had had 40 years of experience as a psychiatrist. And yet, when I was about to do it, I turned to a colleague who's done many, many of these forensic evaluations for help. He sent me a copy of one of his evaluations, de-identified, which I could use as a template for my own evaluations. And after I did the draft, I sent it to him and he reviewed it and we talked about it. I made some changes before sending it to a lawyer. And this is what mentorship is. This is what I now do with people who I'm mentoring. And the reason for that is that psychiatrists particularly have well-developed skills in important areas in terms of interviewing, conceptualizing, and reporting, but they have to be modified. There are some things we have to unlearn and some things that we have to change. Kind of the next slide. So a psychiatric evaluation is different from a forensic evaluation. In format, the psychiatric evaluation is a medical record, so it's part of the medical record. It involves a patient-doctor relationship. It's confidential, and the patient is told that. And the purpose is treatment. The forensic evaluation is a legal document. It's an affidavit. It's not part of a medical record. There's not a doctor-patient relationship. And the format is a report for the court. So the applicant is told right at the beginning of the interview that there's not confidentiality. They're also told that if there's anything that they don't want to be in the report, they should either not talk about it, or if they do and decide they don't want it in the report, they can tell me that and I'll leave it out. But that has to be made clear. And the purpose is not treatment. The purpose is support for the asylum application. Next slide, please. So the goal of the psychiatric evaluation is to make a diagnosis or diagnoses and to develop a treatment plan. And in order to do that, you want to do an extensive, comprehensive history and formulation. The more information, the better. And ambiguity and complexity are part of the picture. It's what some of us enjoy about being a psychiatrist, is that we can wrestle with those things. In the forensic evaluation, there's very specific questions that we want to answer. First, is there a psychiatric diagnosis? And secondly, if there is, will the condition predictably worsen if the person is forced to return to their home country? Now, we may know, and they may know, that they'll be killed if they return, but that's not in my purview. That is left, I'm told, to country experts who will have their own ideas about that. What I can talk about is the psychological state and whether that will worsen or not. And then finally, and maybe as important as anything else, is the client being truthful. The fact that it's an evaluation and that I am a medical professional gives weight to my opinion, which is probably the most important question in this whole process, is whether the client is being truthful about this or not. So in order to do this, there's a specific format. And I've actually changed over the times that I've been doing this in some important ways from what we were taught in the initial training. This part of the training is to be as concise as possible, including only relevant information. And there are several reasons for that. One is the hearing officer, I was once told, has 20 minutes to review everything that they get from the lawyers. The applicant statement, my statement, any physical evaluations, medical records, everything. So one of the things I do is I start my report with my findings and diagnosis and recommendations, so that if they're just glancing at my report, at least they get that, which is the most important part. The other reason to be concise is the more information you include about what happened to the person, the more likelihood there is that there will be contradictions or inconsistencies with their statement. And the hearing officer is looking for that. In determining whether the client's being truthful, they look for any, they say they were beaten by 3 people and I say it's by 4 people. That's a problem. So what I say in my reports and what I advise the mentees to say is that that my interview is completely consistent with the client's report, and I won't repeat the report now. In order to do that, I do have to get all that information in the interview, and I do go through what happened to them. But as much as possible, I don't include that in the report. Just a 1 or 2 sentence summary at the beginning to explain the diagnosis. So we do simple, clear, focused statements, avoid contradictions and inconsistencies. And in my experience with mentees, this is the hardest part, being concise and focused. They have spent years learning how to take a large view and include everything. And I keep telling them, leave that out, leave that out, leave that out. So the process of being a mentor is I first meet with a person briefly, just to arrange how we're going to work together. Then I send them a copy of a de-identified evaluation, because that makes writing evaluations much, much easier if you have a format to use. And they send me the client's statement. We each review those things, and then we meet before the interview. This is all virtual, the meeting, and talk about, based on the client's statement, what you might expect in the interview, what to focus on, what to particularly query. And then, for instance, recently there was somebody who had a very, very good case for asylum, but years ago had been convicted of cocaine trafficking. And that, to my astonishment, that person ended up getting asylum. But it was important to think about how to explain that, the connections between that experience and her diagnoses, which could be done. So we talk about what may be coming up. After the interview, we meet again virtually, to review the draft of the statement. And that's when I do a lot of cutting and slashing, and also clarifying. And we do that for several iterations, sometimes 2, 3, 4 times, until we get a statement which I believe will go to the lawyer and without any changes being asked for. And that is what has happened so far. When I started doing these, I had long backs and forths with the lawyers to get it, not to make anything up, but to clarify, to include, to exclude. And in the people that I've mentored so far, that has not happened. The lawyers have been satisfied with their conclusion. And I think it's been very helpful to them, and to the extent that it leads to positive outcomes, will make it more likely for them to do more. Next slide, please. So this is me and my email address. If you have any questions or if you want to talk about mentorship, I'd be happy to talk. Thank you. Back to Wyatt.
All right, I'm just going to breeze through this last little bit so we can open up for questions. Again, another QR code, just again, the same link to our website, the Tufts Human Rights and Asylum Clinic. If you're at all interested and involved or have any questions at all, our contact information is on that website, as well as soon details for our next in-person training, which will be held in November. We also have a link. Oh, I did want to briefly mention that obviously medical students are involved. We have residents who are involved in this program. Since this is about education, I felt I should plug that, as well as medical professionals. So we really try to involve all levels of the medical education process. The way that med students are involved is obviously different than people with medical degrees, but we still try to tackle every angle. Though Dr. White alluded to the fact that these are very important, these are life and death cases for people if they aren't granted asylum, and having a forensic medical evaluation can more than double their chances of, or practically double their chances of getting asylum. So if you had a medical treatment that was, having people's risk of mortality, it would be something we were very significant and we would talk about. So I just wanted to include that data there. And then finally, plug for this remote training. So our next training in person will be in November at the Dana Center in Portland. There's this free online training. Here's another QR code. You can take it at your own time. It takes a couple of hours, but you get certified to do these examinations. And then you can contact us and we can connect you with people who are looking for these evaluations, and you can get right into this very important work. So I will leave it either on, here's some more resources that you can scan a QR code quickly, but I'll actually leave it on the CME slide here as we open it up to questions from the group, in case anybody missed that at the beginning. And thank you again.
Thank you very much. I invite everyone to turn your cameras on. And I know Callie had a question at one point, but folks, just feel free to raise your hand. And we'll
thank you
moderate
so
them in.
much. This was a great presentation. I really appreciate it. OBGYN worked in resident clinics really for the entirety of my career, and have been involved in a lot of these asylum cases. I just wanted to add to the list of physical findings. We've had several situations where in Portland, specifically Somali patients have brought in young girls who have not been the victim of female modification, and so doing a physical examination to prove that, to support asylum status, has been successful in every single one of those cases that I have been involved in, which are quite a few. And the only other thing I wanted to say is that we, over the years, I have been involved in several forced sterilization cases, and a hysterosalpingogram was actually a very useful diagnostic imaging tool that confirmed that the fallopian tubes were in fact blocked. And so it was helpful in the two cases in which that happened to have that as well, just as a corroborating. Obviously, it could have been anything, but it was definitely a corroborating imaging that helped with that. So two little OBGYN things.
Thank you for sharing that. And there is a huge need for evaluators who are able to do these GYN evaluations. We have a huge mismatch of cases that involve female genital cutting or female genital mutilation here in Portland, especially, and not enough providers who can do them. So thank you for bringing that up. It's a very important part of the work.
I'd actually like to share a question from Annie Durthik. She's having some audio issues, but she did put in the chat, is there a role for advocacy in the work that you do, especially given some of the current political climate?
Absolutely. And this is actually something I might turn over to my other co-leader, Hannah, who just recently was doing some advocacy in Augusta around a different issue. But there is certainly a big role for even just telling your congresspeople about this, or your administrators in whatever institution you might be in about this. I don't know if Hannah had anything that she wanted to add about that.
You're muted, Hannah.
It actually appears, I don't see the mute sign, but I wonder if your microphone's giving you trouble.
No. Well, I would say, I'm sorry I don't have more information about that as Hannah tries to get her mic working, but that's definitely something that I think if you're excited or interested about doing advocacy work, please just reach out to us, and I can put that QR code back up on the screen for our email, or even just if you wanted to throw something in the chat, and we can get back to you about opportunities that there would be to you know, write opinion pieces or go and advocate. Yeah, in Augusta. Thank you.
And White just heads up, you're sharing the screen of the
Yes,
screen. It's very
yes.
meta right now.
Yeah, here I'll put these back up here.
There we go.
Yeah. Wow, so that's to our website.
Any other questions, folks? I guess I'll ask a question. Thinking about teaching and mentors, I'd be curious just to hear what has been the challenge in teaching medical students, residents, other physicians about this process. I guess where do you, as an educator, where do you anticipate challenges and what have you learned to overcome them?
I don't know if you want to, did you want to mention something, Wyatt, or?
No, I'm not so much an educator as an educatee. So I'll leave that up to you, Dr. White or Dr. Mills.
I really haven't met any challenges to it, both in New York and in Maine. The starting at the medical school level has been one of the most successful efforts because the students get involved in the process, the thinking behind it. And certainly at that early age in their career, they have time to participate in advocacy or to help with the actual administrative aspects of matching the evaluators to the asylum applicants. So they are already contributing by doing that, and they find that very satisfying. Usually during training, people do take the training for evaluating asylum seekers, but trainees often don't have time to do the actual evaluations. It is when they are out well established in their career that they then get there's a new revival in interest. But I think that one of the issues is that many people go into medicine because they want to make a difference. And if we can introduce the idea as early as medical school, I think that they will carry that on for the rest of their career, and we won't have this wide space of time where they are not able to do this work, and then until they have more flexibility in their careers. So I think the biggest boost is to introduce it in medical school curricula.
I would say for mentorship, the biggest problem, I think, for people doing the evaluations is feeling alone with them and uncertain how to do it, and having somebody who they can turn to for help, I think, has made a real difference. The people that I've worked with have been very receptive, I've worried a little because I keep, as I said, cutting and slashing their reports, and they seem to be grateful for that and happy when it works. I'd like to give a really quick example of the difference that I forgot to include. As a psychiatrist, I learned that the best kind of report is verbatim. So I use a lot of quotations direct from the patient. And early in one of my evaluations, a lawyer said that putting it in quotes makes it seem like I don't believe them. It's like air quotes. And so please don't put things in quotes.
Interesting.
Paraphrase them, which I thought was fascinating. Thank you.
I'd like to point out in the chat, just before, for the recording's sake, for anyone watching, they won't get to see this comment that came in from Hannah. She says, apologies for the audio issues, but they do advocacy at the medical student level, working to raise awareness throughout medical schools about the need for forensic medical evals and familiarizing students with asylum seekers and the challenges they've faced and their medical needs. They don't currently have any formal legislative advocacy programs, but may expand into that in the future. And it's kind of a great way to put a cap on all this. It's amazing work that you're doing. We're so grateful that you presented to us today. Certainly, folks, you saw some contact information there. And as always, we'll present this on the Merge website and the Building Maine Network website. It's also up on the iHELP-Maine Learning platform. So lots of ways to access this material. And before we go, I always have to give the teaser of what's coming up next. Next month on May 9th, it is Coaching the Medical Learner. We're so excited. Corey Smith is a PsyD. He is the Director of Behavioral Health Education at the Maine Dartmouth Family Medicine Residency. And part of his credentialing is specifically working towards his CMPC, which is a certificate as a mental performance coach. So a really interesting background. And I think as we work with folks and mentoring and coaching, knowing the difference, it's going to be a great presentation. So hope you'll join us again at noon on May 9th. Until then, thank you, everybody, and have a good one.
Thank you.
Thank you
for having us.